And I'll pull up my quick intro slides. So welcome everybody to today's Project Echo session. Today we've got a good presentation from Dr. John Massey on deprescribing. So I'll go through our usual intro slides here. Again, this one just says that all of us involved in this effort today don't have any financial relationships to disclose. We're not here to promote anything. These are free grant-funded trainings. And we are funded by a SAMHSA grant from the State Opioid Response Grant from SAMHSA. Those grant funds come to the Nebraska Department of Health and Human Services, Division of Behavioral Health, and then they're passed on to us. So we would like to thank our partners at Nebraska DHHS for helping us make these trainings possible. Again, for those of you who were here last 2 weeks ago, the CME certificate will be the same way. I'll send out a link. You do that quick 1-minute eval survey and your certificate pops right up. Pretty simple. And then again, I think everyone here knows what Project Echo is, but for those who are new, Echo stands for Extension for Community Healthcare Outcomes. And these are trainings and consultations related to treating patients with substance use disorders and/or pain. This is sort of a hub and spoke model where we've got a great team of 6 experts as our hub team. And sorry, pause for 1 minute here. I got people coming through my waiting room here. Sorry about that. So yeah, it's a hub and spoke model. Like I said, 6 experts who are able to consult with you on these trainings. These trainings encourage participation from the audience if you're interested in wanting to present patient cases or ask questions related to treating patients with pain or substance use disorders. We could also have time outside of these trainings to consult with one of our experts. So please just contact me and we can make that happen. That's part of this project is consultation and mentoring. And then these will be kind of ongoing trainings. We've got a series of 4 trainings scheduled right now. This is the second in that series of 4. After this series of 4, we'll be getting together again and putting together another series of trainings on kind of within the same realm of pain and substance use disorder. So I'll make sure everyone knows about these our upcoming trainings. And then our hub team. I'd like to introduce our hub team. In fact, I'd like them to introduce themselves. So I will stop sharing my screen here. Here. And I'll just call on our hub team to introduce themselves. Janet, would you like to go first?
Yeah, hi, I'm Dr. Janet Bernard from North Platte, Nebraska. I'm a retired family medicine person. I practiced for 35 years. I retired at the end of 18, but continued doing opiate addiction treatment through Region 2. That's it.
Thanks. Ed, would you like to go next?
Yeah, you bet. Good morning, everyone. My name is Ed Kaiser. I'm a nurse practitioner here in Omaha, Nebraska. I currently work for a company called Ideal Option, which does substance use disorder really across the United States. We do have a clinic here in Omaha, Nebraska, but been doing that for 5 years. So really excited to be a part of this team and to help people with substance use disorder. It's really rewarding to see people get better. So thanks for letting me be here.
Thanks, Ed. Stephanie, would you like to introduce yourself?
Yep, I'm Dr. Stephanie Bennington. I'm a psychiatrist here in Omaha. And I currently work at North Point, which is a new residential substance facility that we have that's been open for about a year. I'm currently adding more time on the children's side, and that's been open for about 4 months. And it's really going well. So it's nice to see you all here.
Thanks. 2 of our experts aren't able to be on here. Gail Keller is a psychiatric APRN from Falls City, and Todd Stoll, psychiatrist in the Lincoln area, aren't able to be on. So John, I'll let you introduce yourself and take it away for us.
All right. Hi, guys. I'm John Massey, and I'm an interventional pain physician. I live in Lincoln, practice in Lincoln, and a number of other communities really across the state, and I've been doing this a long time. So I have a high number of patients that are kind of comorbid pain and substance use disorder, and working with those kinds of patients. And so that's how I got interested in this. And that's kind of part of what I want to describe for y'all today, trying to bring a presentation. So how about we get, Will, you gotta allow me to share my screen.
Sorry about that.
That's fine. Okay, so this is kind of an interesting time in this area, in this space. There's a lot of increase in interest in the best management of these kinds of patients, and there's a lot of changes in, I'm going to see if I can get this right, folks. Tell me how I'm doing. You don't see it yet, do you?
I can see it. I see kind of
My
the,
Zoom. You don't see my,
I see your the speaker or the next slide and the speaker notes. If you can make it
see if I can,
all like make it bigger, I guess.
yeah. Always a trick, isn't it? Hold on a second. So, how about there? Does that fix it?
It looks the same, but I mean we can see it well enough if that's
I don't want to see if I can fight through it a little bit better.
If you go to display settings, it'll tell you to switch the screen.
At the very top on the left-hand side.
Yeah, it just changes when you put on the screen share already. Let's see here. All right, let's just talk and I'll figure it out as we go. You're going to start seeing my slides better in a minute. Huh. No, that doesn't fit it. Sorry. There we go. I'm expanding my screen. Okay, so fundamentally, what is interesting about right now is everyone knows. Can you see at least my graph slide? I'll try to figure it out here in a moment. And can you see my graph slide on your screen? Anyone?
Yeah,
Yes, we can see it.
Yeah, we can see
We
it.
can see
We've
it
seen
if
this graph a million times, right? What we know is there's been a 400% increase in prescribing of opioids beginning in 1999 with kind of bad evidence. Till about 2012, we were prescribing foolishly, maybe in a fashion that was not going to work in the long term. And then beginning in about 2012, the attention from all the different federal agencies brought forward the idea that we should prescribe differently. So we started deprescribing, and then we pushed a bunch of patients who are now not doing well. We pushed them into illicit substances and or all the problems associated with that. And then of course you get the so-called third wave with the fentanyl derivatives and things going up. So there's a lot of attention about opioid overdose deaths, which are terrible and increasing despite our efforts, largely because right now, because of the adulteration with fentanyl and many other substances, but also we're not doing our part as a house of medicine because of kind of our frustrations with it and the fact that we maybe don't have all the tools in our toolbox to manage this. So there have been some regulatory responses, and that's part of what brings this grant to us today. Most of you guys are aware of the fact that in 2017, the CDC came out with guidelines that sort of described the best practice for prescribing opioids. That's where we get the MME caps, where we get information that talks about the 500% increase in mortality with co-prescribing of benzodiazepines and all those other things. But the House of Medicine, being the House of Medicine, these guidelines were then misused, not necessarily entirely by clinicians, but oftentimes by payers and other hospital associations and what have you, because people, how many times have you had some patient tell you that I'm not allowed to prescribe more than 50 or 90 MME, I need to deprescribe for you. And so patients say, well, I have to get off because I'm on too much medication, and or they won't allow me to XYZ, which is specifically then came out in with revisions. Both the FDA and the CDC came out with revisions in 2022 saying stop doing that. The reason that's a bad idea, of course, is that when you deprescribe for individuals, then there's a whole host of other morbidities that come into play, whether it be an increase in suicidality or an increase in them going out and trying to get medications illicitly and what have you. So basically, there are issues with patient abandonment if you have a patient who's been prescribed perhaps in a fashion that isn't best practice, and now you want to wean away from this. So in the midst of this, we've had this kind of story of the DEA X waiver, and we've been involved in the process of training as many clinicians who are interested in the data waiver and getting the ability to prescribe opioids for office-based opioid use disorder treatment, and that was removed, and that was removed because really, when we look at the risks associated with buprenorphine therapy, we find that it's a molecule that can help a lot of patients, and I'm going to talk about that for most of the day, but also the idea that it stigmatizes treatment for patients with any kind of substance use disorder, and they're trying to increase the number of people who are comfortable with this and who can manage this, because the population, the epidemiology is just overwhelming. There's just a shortage of people. So we're glad you're here, and we're hoping that this is the kind of thing that can bring you to therapy. My specific, and what I'm going to try to talk about is what all of the different ideas are around how to manage these patients. But I'm bringing a perspective as a clinician who has been managing chronic pain states for more than a couple decades, and because I'm an old guy, I tend to get the difficult patients and the patients with comorbid diseases. And what I have found is that if we can use the right understanding of this disease process, it's always possible to prescribe in an appropriate fashion. So when I wrote deprescribing in my title of this, I understand that to be a controversial idea. We are not here to deprescribe for people in order to make them more uncomfortable or cause problems. We're here to manage their suffering and improve their safety. And my whole thesis today is you can do both together. It's not one or the other. So I hope you can understand this. What are we talking about this? When we're talking about persistent pain, understanding today, we're not talking about the individual who primarily comes to the use of medications for illicit reasons or recreational. We're talking about individuals who have maybe been in the healthcare system and have been prescribed in a suboptimal fashion. So when you're talking about an individual who has chronic persistent pain, it's not just a physical symptom, right? It's got all the hallmarks of a disease. It has functional loss. Patients lose their ability to be productive within their life, have meaningful relationship. They develop comorbidities from an affective or mental health condition, whether it be depression, anxiety. We talk about PTSD, but really I kind of prefer to think about it as trauma. When we talk about trauma, we know that individuals with chronic pain have a very high likelihood of developing adverse childhood events. And those are part of the reasons that bring people to maybe not have an initial state of pain, but have a type of pain that is refractory to management. So the fact that these individuals have a morbidity, a comorbidity of mental health disease is very important in our management strategies. So keep that in mind. Naturally, sleep disturbance comes along with the physical symptoms, as well as some of the other secondary physical problems. But fascinatingly, right, we can just embed opioid use disorder right in the middle of that same kind of conundrum with respect to chronic pain. SAMHSA just simply pulled out persistent pain and opioid use disorder and find that it has the same kinds of things. So what I would encourage everyone here, and this is what I really hope we can bring back from this, is that chronic pain state and substance use disorder state, not just opioid use disorder state, but substance use disorder state are physiologically very similar and very interlocked. So as a result, we find that management principles are very often similar. So when we come to a group and we say, does anybody have an interest in starting up some MAT or MOUD medication for opioid use disorder? tons of people are like, nah, no, not me. I'm not interested in that. But the same cohort of people would say, all right, well, does anybody have a partner or some patient they're taking care of that might be getting medications in a very difficult fashion and they're not doing well? They're running out of their prescriptions. They're outside of what you would say best practice, and yet their symptoms are persistent and you don't know how to move forward without deprescribing. Then you get a number of people who raise their hands and say, yeah, I have that kind of patient. What do I do? So our concept here is this is how we do this. You have to talk a little bit about why it works and what's important and when it works versus when it doesn't work. So I'm sorry for a little bit of pain physiology. I always have to throw it in here, maybe because it's how I see the world. That remember ourselves that there's different physiologic subtypes of chronic pain conditions. We have nociceptive pain, we have nerve-related pain, and then we talk about central sensitization for a number of years. And I kind of like the term nociplastic a bit better now. But fundamentally, what we're seeing with pain physiology is that it's not a phenomenon of tissue. Chronic pain is only partially, if at all, related to ongoing tissue changes. So when I see somebody who's had a history of low back pain for 40 years and they've had a 2-level fusion and a surgeon's trying to figure out if they want to fuse them the rest of their spine, and they've had persistent pain and it's radiating into their legs and they're not able to sleep, they're inactive, they've lost their job, and they've had all these other issues that you can identify, we really have to be responsible about saying, all right, is more treatment for a musculoskeletal cause going to be beneficial or detrimental for the patient? And that's because the nervous system, especially the central nervous system, is not just a bunch of wires like we're wired in a house. It's more like a computer network that's constantly learning. Put in the concept of AI, it's constantly evolving and changing. So if you're going to make this neurologic system transmit a signal, it's going to become efficient at it, and it's going to augment the pathways. And guess what? The pathways that it augments are traveling right through the same areas where mood disorders and substance use disorders kind of can develop. So pain physiology, and when you look at this graph here, nociception is just a part of this. So when we have a nociceptive pain, I break my leg, I go to the emergency room, opioids are going to be the most effective treatment for that. That's because it's a tissue injury state and all the other things haven't begun to develop. Maybe they won't, but they're not developing, so it's not a condition. Same is a little bit true with so you can treat nociceptive pain with all the things that we know about and we talk about all the time, all the kinds of agents that work, the NSAIDs and opioids and what have you. You're basically treating the tissue. Once the tissue is treated, the pain gets better. Neuropathic pain or peripheral neuropathy or neurogenic pain is kind of nociception or abnormalities of peripheral nerves. So when you have the changes that diabetes creates, or maybe persistent alcohol use creates with nerves, you're getting axonal changes, you're getting changes to the membrane, the glial cells, and what have you. The new nerves in the periphery are being denuded, maybe from ischemia. Now you get nerve pain in the periphery, and that's a problem that's primarily in the peripheral area. But again, it doesn't last in the periphery for very long. We can show that there are changes within the dorsal root ganglion that occur that amplify this very quickly. So that's why things like our central agents work so well, duloxetine and what have you, work for neurogenic pain. But particularly important in that is that neuropathic pain doesn't respond to opioids, aren't effective for neuropathic pain. But chronic pain, chronic persistent pain is fundamentally more and more over time related to central sensitization and or nociplastic changes. I always try to tell patients that, you know, we can watch ads on TV for these miracle things that the nutrition companies are going to try to sell us to help our memory because, you know, the science of neuroplasticity, and you take a supplement and all of a sudden you can remember things better. And, you know, it's certainly taking advantage of desperate individuals. But what individuals do learn from that is neuroplastic changes occur, right? We can tell somebody who maybe loses their Wernicke center and they lose their ability to speak. They can later learn to speak with a proper care, not by fixing the damaged Wernicke center, but by developing a new one in another part of the brain, right? But nociplastic, neurogenic, neuroplastic changes aren't good or bad, they just are. And so if you're doing something repeatedly, you're going to have augmentation of that process. So if somebody has a persistent, unrequited pain over the period of time, it's more and more associated with neurogenic changes within the central nervous system. And what's fascinating about that is those neurogenic changes, what happens is this signal comes in through the dorsal horn, crosses over into the contralateral anterolateral horn, and goes up into the two specific tracts. It goes into the spinal thalamic tract and the spinal mesencephalic tract. So those first order neurons cross over in the synapses in the dorsal horn, travel up through ascending limbs, and they go directly to the limbic system or the mesencephalic area. And what's going on in that area? That's the area that has modulation with respect to affective illness and or substance use. So when you have an individual that has this persistent incoming signal, then that area becomes involved and all those other changes occur, even before this goes off to the somatosensory cortex, prefrontal cortex, where you get all your descending inhibition. So the fascinating part about this is the augmentation of chronic pain is physiologically related to abnormalities within the same structures that cause an abnormality for substance use disorder. The other part about that is, therefore, that gives us an opportunity to treat this. What I want people to understand, therefore, is that the concept of pain and substance use disorder is more a continuum than a distinct set of circumstances. What goes on then is when we treat one, we're treating another. And you see aspects in chronic pain that show very similar behaviors and or responses to different types of treatment with the same kind of area. And this is basically saying the same cycle that's involved in substance use disorder is involved in chronic pain. So it's very natural to understand where the medications that might make one condition better would also help the other. It's also really fascinating when you look at some of the epidemiology of this, when you understand that 5% of chronic non-cancer pain patients use up 70% of the total MME of opioids in the country. And what's similar about those individuals is that a lot of those individuals have developed, for one reason or another, either before, after, or during, they develop dopamine dysregulation. And individuals with dopamine dysregulation are more likely to develop problems with chronic pain. And the fascinating part about this is there's nowhere else in medicine in the US where you get such a mismatch between providing medications for individuals and the fact that the ones who are getting it are exactly the ones who shouldn't be or who won't possibly benefit. And that's a lack of education on the part of clinicians. And it is our charge, and that's why we're glad you're here today. So what we see is the people who are prescribed are typically young people with more pain diagnoses, and they have unrecognized or maybe undertreated, unrecognized comorbid mental health conditions and or substance use disorder. And what's fascinating about that is we have a misperception about who's at risk for developing these problems. And, I have a ton of patients that get sent to me who maybe they're getting, the primary care doctor doesn't want to give them 3 hydrocodone a day because it's an 80-year-old lady with spinal stenosis, and they're worried about this little lady falling. Fantastic, I'm interested in that. But the same patient may come in who's a 35-year-old who might have a history of, ongoing tobacco use, probably an alcohol, heavy alcohol binge drinking, and they're being prescribed because somebody told them they have RA or what have you. So they don't recognize it. When we look at their first order family members, we see individuals with substance use disorder of other kinds in there, or maybe these individuals have an ongoing different substance use disorder, and we're not recognizing the risk of that. So think about this a little bit more clearly and recognize that abnormalities of the different neurotransmitters lead to persistent chronic pain, right? We understand that the body is sensitive. Dopamine is kind of that boogeyman with respect to what's causing problems with dopamine or with substance use disorders, and dysregulation of dopamine is associated with the effects that lead to individuals to continue to use, and also gives them the physical symptoms that's the impetus for using, right? So when an individual has, and it's not the amount of dopamine, it's the rate of rise or the rate of fall within the CSF of the dopamine that we're very sensitive to. And when the dopamine is falling, they get dysphoria. And what does the dysphoria do? It mimics the symptoms of physical pain, or it produces symptoms of physical pain. Same with opioid peptides. When opioid peptides are doing that and they're falling within the CSF, an individual says, I have pain. Serotonin is a neurotransmitter. When you when you get a decrease in serotonin within the CSF, that creates dysphoria and GABA and what have you. So really the abstinent state, if you're using medications that aren't effective, the abstinent state is what's reproducing pain, which is very, very much in line with what we're seeing. And the fascinating, another part about this is all below the level of our ability to think about it, right? When you get changes in the dopamine neurons from the ventral tegmental area, and they see something that says, hey, I need to do this because it'll make my pain better, whether it's take a medication or lie down on the couch or something. And then that signal goes within the deeper brain structures to the nucleus accumbens, which is again associated with use disorders. It makes changes in activity even before this even reaches the prefrontal cortex. So your ability to make bad choices can occur before you even know you've made a bad choice. And so what we get is this kind of reinforcement of things that aren't working and a negative enforcement of things that would work. So when the dopamine is going up, you want that, you associate that with reduction in suffering or symptoms, and you reach it out and you do more, versus when you have the abstinence, you develop problems within the amygdala that are associated with anxiety, fear, distress, and a patient will interpret that as an increase in pain. So what's going on here? How do we fix this? What do we do for this? So individuals are really, one of my soapboxes, and I think it's important that we continually distress, is never use the term drug-seeking behavior. Behavior, by and large, there's a short number of people who are trying to come in and get medicine, purposely manipulating you. What they're doing is trying to find a way to relieve their suffering in the only way they know how, because it's the only thing that we have exposed them to. So drug-seeking behavior is a fault of the house of medicine, not the patient. So when you set yourself apart from the patient and say, I don't like this because it's drug-seeking, we're the ones failing. It's not our patients. So what they're trying to do is they're trying to fix their neurons. They're trying to make a better environment for relief of chronic pain by exposing themselves to the very chemicals which propagate problems in the future. Talked about this a little bit. So what do we have to do? We have to sort of normalize that system so that we can set the groundwork to make improvement and to get relief. And what we're seeing is all the things that we do to sort of, I would say, artificially cheaply treat this condition is fooling ourselves that we're going to make a difference. So the fascinating part, again, once again, I maybe overemphasize this, but how many times do we spend hundreds of thousands of dollars trying to treat a patient with some surgical means when the problem is really fixing the central nervous system pathology, which is more effective, more sustainable, as well as safer for them and less expensive as well. So how do we understand, how to work with this cohort of patients and what we see? And it's a pyramid. It's always a pyramid, right? The total chronic pain population is huge, 50 to 100 million Americans. And then the accumulation of aberrant medication taking behaviors, again, aberrant medication taking behaviors are not a patient misusing medication purposely. They're losing the ability to manage their symptoms because they're not working. So they start to develop an increase in behaviors which reflect a lack of use, successful use, and they start to develop. And if we don't recognize that early on, we're going to get this patient all the way to a substance use disorder. Talked about this. I've talked about this before, but do we even ask the questions of our chronic pain patients about unhealthy use? Because we know there's a lot of overlap, right? So if you talk to somebody, how many times in the last year have had 4 or 5 drinks for men or women in the last year? Have you ever had any in the last year binge drinking? If the answer is yes, that's a high risk, right? That's a simple screen we should all be asking. The same is true with drug use. In the past year, have you used an illegal drug or a prescription medication for non-medical reasons? If anyone says yes in the last year, that's really a screen that's positive, and we need to reflect our treatment based on that. It's beyond our scope. We talk about this in current opioid misuse measure. We train people to use this and what have you, but fundamentally a screening test like early on see a patient who's losing benefits from treatment. I'm going to go past this. So then we get to the concept of, people say, I don't want to be managing opioid use disorder patients, or how do you give somebody a DSM-5 criteria so that I can prescribe buprenorphine for them? And my answer to that is, who cares? We don't need to do that. Opioid dependence is physiological state before it's a psychological state, right? And opioid use disorder is developing and kind of marching up that pyramid, as we say. But opioid dependence and opioid use disorder talk about, how far they've fallen into the abyss. And what we see is these people get better very quickly if we do the right thing versus the wrong thing. What's the difference though? And so when I see somebody, I work in a substance use clinic, and my primary practice is in pain practices throughout the state. And I've really been fascinated because my patients in a substance use clinic, they make it easy because they come in and they say, yeah, I got a problem with, fentanyl or what have you. They're ready for their MOUD. My chronic pain patients are we have to be very careful in our communication because they come in specifically to get relief of pain. But what they don't know is we need to get them away from their legacy opioids before their pain symptoms get better. They have the misperception that I'm going to make their pain better if I do something with respect to increasing their opioids or do something fancy that I can do surgically. But fundamentally, getting them to understand that this is the similar thing and we use the similar concepts is important. And if you learn to use that in your practice, you're going to be happy. So be exploring, the degree to which they've lost their control, they're using compulsive, they're continuing to use despite harm. Harm might be, I lose my job, I'm sleepy, I'm unable to X, Y, Z, and I just need the medication is kind of craving, right? It's not drug-seeking behavior. But it comes in on a spectrum, and we have to be more sensitive to recognizing that spectrum, because it's really easy to diagnose somebody with flagrant use disorders, right? Their life falls apart, they're disheveled, they're here, they're desperate, they're kind of showing all those behaviors that we can talk about. But it's more important to identify those people early on when it's easier to get going in treatment, especially when you can bring them to something like buprenorphine and all of a sudden their symptoms of pain are better. And now we're not worried about respiratory arrest and we're not worrying about problems developing. So understanding, first of all, being confident in understanding those concepts allows you to have a good discussion with the patient. It allows you to be respectful for the patient and addressing their needs, because when they come to you and they're on prescription opioids or other medications to manage symptoms and it's not in their best interest, our job is to say, I respect what your issue is. I want to make your problem better. I need you to see that we got to go in a different way. That's a lot different than saying the system won't let me prescribe more than 60 MME of morphine. I got to take you off because I don't care about your pain. I'm worried about you, not breathing and what have you. To tell the patient, to sit with them and to say, yep, I can make you better. We got to go in a different direction. And it's a lack of education on the part of medicine that we don't do that. So here's something I think is a point to bring to patients, and I try to bring it to as many people. We have an idea that there's a trade-off between successful management of chronic pain and prevention of medication misuse. And that's simply not true. It's never possible to successfully treat chronic pain in the face of untreated or unrecognized addiction. Say it to yourself all day long, every day. If the patient is developing misuse behaviors, they're never going to feel better until you can make them get away from that problem. That physiology is creating the misuse is the same physiology that's creating the chronic pain. So break that cycle early and confidently. And the nice part about this is buprenorphine is a very good tool for that. I can show you, if I had more time to talk, I can show you that there are studies that say we can reduce high use opioids and improve pain. The VA did one. The VA can be criticized, but they have a lot of data and they do a lot of good things. And there's a study, they took 1,000 VA patients and they divided them randomly they had 300 to 500 MME opioids. And what they did was they took one set of cohort of patients and they kept them in their medication, and they did all the things that I can do as an interventionalist. And at the end of the 6-month period, they found out that they still had pain 6, 7, 8 out of 10. The other half they assigned to buprenorphine therapy, and they switched them into buprenorphine therapy, and they did the same kinds of things. And at the end of the 6 months, the buprenorphine patients were 2 to 3 out of 10 on the VAS. And they have all these other ways to measure success because VAS isn't very good. But fundamentally, what that tells us is even high dose, maybe especially high dose opioid patients, do better with chronic pain when they are not taking high dose opioids. Another study shows us that 97% of patients who are switched from high MME opioids outside of what we recommend or the CDC would recommend, and we move them into buprenorphine therapy, 97% of patients prefer buprenorphine for their chronic pain than prefer their high dose opioids. Think about what that means for us, is how many patients we are inadvertently exposing to medications which put them at risk when we can do something simpler and better, more sustainable, certainly more cost effective by switching them into buprenorphine. And why we don't want to do that is because I should say this differently, but I think that's what was wrong with the data waiver. We kind of stigmatized inadvertently the treatment of opioid use disorder as if it was a distinct thing that needed to be put off in a corner and only a subset of people can manage it successfully, like Dr. Bennington and everything. When really what we're seeing is this is kind of all of our problem to fix. And we can do so if we just learn how to use buprenorphine. And the whole trick is, and what I want to talk about a little bit, is how we do it. And in the past, we've had a lot of discussions how you initiate buprenorphine therapy. You know, you have to people be abstinent and what have you. But with the advent of microdosing, we're able to do this very effectively without confronting the patient with the concept that we're going to get you into Suboxone therapy or buprenorphine therapy in a deliberate fashion because you may or may not have OUD. And here's what I'm talking about. What we can do is we can translate patients, and this is not vetted here. This is a graph that my nurse practitioner made for me some time ago because I was kind of quizzing her about how she translated buprenorphine therapy. The one trick with buprenorphine conversion to legacy opioids is that it's not a single number. It's a kind of a sliding scale based on physiology. But fundamentally, what we can do is we can take an individual and we can very slowly move them to buprenorphine therapy from their legacy opioids and then find the dose that's effective for them. Here's what I mean. Instead of taking somebody, let's take a patient who's on maybe 60 of oxycodone, so it's a 90 MME, it's something that's not very effective. What we can do with an individual is we can give them 1 milligram of buprenorphine therapy daily, sublingual, as they're being prescribed their medication. So they're getting their ongoing opioids, and we're just giving them a sublingual buprenorphine. We're slowly filling up the receptors because, as you remember, buprenorphine is very tightly bound to the receptors and it has a very long half-life, but it builds up very slowly as a result, right? It takes 5 half-lives to reach steady state, so that takes about a week. So we put 1 milligram daily for a day or two, so it's half a pill, while they take their medications. And then we take another milligram Q12 hours for another couple of days. And now what we're doing is we're filling up more and more of their mu receptors, and we're not making them wean away from their opioids. When they get to 2 milligrams, sometimes we'll go 3, but roughly 2 milligrams, we're going to make a decision. And the decision is going to be, all right, now we're going to move forward with our medication, and we're either going to go higher on the buprenorphine or we're going to stay where we are, but you pull away the other opioids. And what's interesting is individuals, so an individual who is not really fully down the dependent physiology is going to be more responsive to lower doses of buprenorphine therapy, as we might suspect. So an individual who, if somebody comes in and they're like, I just don't want to take 4 hydrocodone a day or more, I can put them on microgram dosing of buprenorphine and just stop their opioids, and they feel better very quickly. But an individual who's starting to develop that dependent physiology, which means they're more responsive to fluctuations in their dopamine, they're going to need a little bit more. So what we can do is we can gradually institute that buprenorphine therapy as we wait on their others. And then when they get to the point where they're getting relief of their symptoms, they're just starting to sort of feel better. That's when we have them on their own, at their own pace, just pull away their legacy opioids. And then they move forward if they need to with buprenorphine therapy, and they just find the dose that's effective for them. We tell them it's not going to eliminate your pain, but we want to do better with your pain than we were doing on your prior opioids. And we don't even talk about, well, we think you're developing a use disorder, you've got these aberrant behaviors that we're concerned about. We're like, let's make your symptoms better, and then later on we can talk about it. Because these guys really aren't in their prefrontal cortex at all when they're just desperate for relief, right? We can have long conversations, we can have the difficult conversation, we can do whatever. They just want to feel better. So if we gradually institute with microdosing technique that came out of Canada, and we move that forward, and Ken Zuha was really one of the people who instituted this in Nebraska, and he did a really good job teaching us this years ago. But if we gradually institute this up of the buprenorphine, and then we just pull away the legacy opioids when they're ready, and they come back and they say, I feel better, and it also has the advantage that it doesn't force us to do something that they're scared about, right? The anxiety of switch is reduced greatly. They're also empowered because they're the ones who are pulling their medication away rather than us dictating it. We do oftentimes give them the direct conversation about that, but the language that we use is important because we want to make sure that we're allowing our patients to be empowered in that regard. So that's a long discussion for Echo, but I wanted to kind of get through the why, and then I wanted to kind of go through a case or two if you guys wanted to understand how we do that. And our whole goal over Echo with this is to help train people if they want to do this. And hopefully what we'll get to is better relief of pain and certainly increased safety. And, you know, what we can find is now we're very closely aligned with CDC guidelines with respect to opioid prescribing, and yet we're getting accelerated relief of symptoms. Anybody have questions about that part before I bring up a case? Nope. Some people are, I don't know, I'm sure most of you are deep in your emails and coffee by now, but let me just bring up a case. And so what we didn't talk about too much last time is kind of the idea of Echo. And really Echo is supposed to be helping individuals come to challenging clinical cases as a hub team and a spoke team. So commonly what somebody can do is we'd ask anyone who participates to bring a challenging patient forward and say, here's what I'm seeing. Any suggestions? What should I be thinking about? So I'll play the role of the person bringing this forward, but we would always want to encourage individuals who are involved in this, bring a case forward, present something, ask questions. We want to be a low stress way to help people with this. So I'm going to present a case, and I'm going to ask you guys kind of ask me questions, give me ideas about what to do. But the first idea is to get participants to ask questions to sort of explore how they would want to address a situation like this. And I'm just gonna go through a couple patients from my last couple of weeks just to do so. So the first patient I see is a 68-year-old gentleman. He's very kyphotic, forward-leaning. He's had multiple fusion surgeries because of this kyphosis. He's essentially fused from L2 to the sacrum, getting a really bad control of his chronic pain. He's here because his physician in Kansas will no longer prescribe for him. He's been prescribed for a number of years. He's had a primary care physician who is at retirement stage, left. His younger replacement came in and took over his medications for a couple of months and then said, I'm out. This is too stressful. This is not what I want to do. You got to go find somebody. And unfortunately, that's a challenging thing for patients. So he's driven a number of miles to come to us, and he comes in saying, my back pain is terrible. I'm not doing well. I can't do what I want to do. I want to garden. I'm retired. And his current dose is MS Cotton, 60 milligrams TID. He takes oxycodone 10-325 5 times a day, cyclobenzaprine in and out, a few other agents, gabapentin, I believe, and Ambien at night. A pain physician years ago put in a HF10 spinal cord stimulator, which doesn't work too well. It works a little bit, hasn't been reprogrammed, and he comes to me because my doctor won't prescribe me. This is the minimum amount of medication I can have to do better. I want to know, will you prescribe these medications for me? Yes or no? Pain scale is 7 to 8 out of 10. He's retired, lives with his wife, who's with him, seems to be supportive, but is tired of him being uncomfortable and not able to sleep or do activities because of his pain treatment. Anybody want to ask me any questions about this guy?
Well, did you start microdosing?
Yeah, that's kind of jumping to the. So
Sorry.
no, I
Okay.
didn't. I did not.
Okay.
Well, let's say this. I did see him. First time I saw him, I said, how's your pain been? How's your control been? And it wasn't very good, right? And he was scared. He was nervous. He was frustrated because he felt like a criminal, right? He even said that. A lot of times they don't say it, but they're thinking it. He just wanted somebody to help him, and he was coming a distance. He had kind of limited resources, and I did not. And I think you don't want to start somebody like that with microdosing right away, because motivational interviewing perspective, you'd never, again, the CDC will tell us it is inappropriate to deprescribe for an individuals simply because they're outside of our recommendations. Specific recommendations in 2022 were do not deprescribe individuals like this because they're at risk of worsening pain, getting substances on the street with 39% adulteration with fentanyl, and or suicidality. So I say in an individual like this, I say, hey, I've got a different idea. I'm not going to do it right now. You don't know me. We're going to stick with this for now, but it's obviously not working. And I'm going to start talking about something in a while. When we talk about the other things that we can do, we kind of scrub around the edges, but I don't do that. And then I had on occasion of two separate instances at monthly intervals, when I follow up with them, I say, how's it going? How are you doing? You remember what we talked about? And he was like, yeah, I'm interested in that, but I'm scared. And then I turned to the family member and I said, how's he doing? And the tears start to flow. He's doing terribly. He's afraid that you're about to deprescribe for him, et cetera, et cetera. We kind of get over that, and we wait another month and we talk about it. And then eventually I got him to the point where we did microdosing. And we had to work on it. We did microdosing, and with microdosing, I did clonidine, clonazepam, all the other stuff, Zofran and what have you. And we got him microdosed, but I followed up with him before I made my full transition because he was so scared. And really part of what I judge is he had resources to get to another place and kind of unwind our therapy. So I saw him at 1 week intervals for a couple of weeks just because I thought I could do it. And we did.
Did you consider a psych consult?
Well, certainly I would consider a psych consult, but what am I going to see? I'm going to see everything, right? He's depressed. He's anxious. He's frustrated by all that, but he lives in central Kansas and he's had those visits in the past and he has an ongoing therapist, but they aren't addressing the other stuff, right? The medications. So yes, an excellent question.
The other thing is the psych consult can work with you in
Yes.
concert
Great point.
to coordinate efforts.
Fantastic point. Should be done all the time. You're right.
Yeah.
Thank you for that, Joyce.
John, there is Ann Hughes has a case she'd like to discuss. So Ann, why don't you come?
Hey guys, I'm Amber. Sorry, I'm home on medical leave, so I'm kind of a mess. So I'm not going to turn my camera on. First of all, I appreciate this series. This has helped me a lot. I'm a psychiatric nurse practitioner out in Hastings, and I actually see. I am I'm dual certified, so I'm the medical and the mental health nurse practitioner for both of the YRTC campuses in Kearney and Hastings. I do medical and mental health at Hall County Jail, and I do inpatient substance abuse at the VA, as well as my own private practice. So I have an interesting group that I love. Anyway, that's my population. I was sent a 53-year-old gentleman who was released from 23 years of maximum security prison in January. Long-term heroin addiction, actually stopped using heroin while in prison by illicitly obtaining Suboxone. So he has been clean now. He's been clean from heroin since 2017 on Suboxone. Of course, was not getting it prescribed through the appropriate channels in prison. So he gets out in January of this year, and see you later. You no longer have Suboxone. And of course, out here in central Nebraska, nobody really wants to prescribe Suboxone, even though the X waiver had been dissolved. So I was referred, and I've been prescribing through the VA since the X waiver went away anyway. So I'm fairly comfortable with it. I appreciate this series a lot because there's a lot I need to learn yet. Anyway, so I get this gentleman who comes to me, and we've been working, collaborating on his Suboxone, and has done fairly well. Although he does have some manipulative tendencies now, and he has a lot of medical problems. He's undergone now a left rotator cuff. He's looking at carpal tunnel. He's got a bicep tendon repair. I mean, this guy's just been beat up over the past 23 years in prison. So kind of coordinating between, and fortunately here in Hastings, I've worked with most all of the providers. So I have a good working relationship with them. And so the orthopedic office called me the other day and said, your patient has stopped taking a Suboxone 4 days ago and is trying to get Percocet. And I said, well, and I'm on medical leave, so he's part of me. And like you said, Dr. Massey, a lot of us get into the headspace of, well, this guy's been in prison, so he's a manipulator. That's all he knows. That's his coping mechanism. That's how they survive. So then your red flags start going up. Okay, he knows I'm on medical leave. Typically, this guy has blown my phone up at least every day with different questions and whatnot, which is fine. I've developed a wonderful relationship with this man. But then, they call and they say, hey, he's trying to get Percocet. He's not been taking his Suboxone. And I said, no. We just increased his Suboxone to deal with his post-op pain. Because he had come to me and said, so of course we work together going into surgery. The education, you've got to, cut down on the Suboxone, so on and so forth. Did great. Then he comes for his kind of post-op follow-up with me and says, the Percocet doesn't work anyways. I'm not taking it. The Suboxone works better for my pain management than the Percocet ever did. So, I'm not even taking that anymore. I'm just managing. But could we go up a little bit on the Suboxone? I said, post-operatively for the next month or two, and you've got a lot more coming up. Yes, I think that would be appropriate. So right now he's on the sublinguals. He's on the 8/2. He was on BID, and I did just bump him up to TID. Now, when I called him the other day after I talked to the orthopedic office, I said, we're not going to do this. We're not, and I gave him my whole, I talked to all of my people struggling, I don't want to set you up for failure. We've got to be really careful. We've got to, kind of go into the whole educational. And he was fine. He said, nope, that's fine. If you don't want me to do the Percocet right now, then let's just stick with what we're doing on the Suboxone. And so that's kind of been where we're at. I guess I don't know if I have any specific questions. I have a lot of questions on, am I on the right track as far as kind of increasing that Suboxone postoperatively. And, I know that he does have a lot of medical problems. I know he has a lot of chronic pain, and we've talked about, their neuropathic pain. And so we've kind of gone over all of this. But he's always,
So-
yeah, sorry, go ahead.
No, you're on the right track. You're running into the limits of his kind of coping. So
Mhm.
here's the thing, there's, there's two ways to manage that postoperatively, perioperatively. One is to stop beforehand, make a decision to switch over, and then switch back, and the other is to increase buprenorphine. The two things that are in the way that are causing this guy, probably what he has is a lack of impulse control more
Very
than
much.
than manipulate. He's not, so, give him the benefit of the doubt. His impulse control says, I need to feel better now. I know
Yes.
oxycodone made me feel better now. And the half-life of buprenorphine makes it a little worse at that. And also, buprenorphine is better for the more chronic physiology than the acute physiology. So if somebody breaks their leg and you give them buprenorphine in the ER that are opioid naive, it will work somewhat, but it might not work as well as fentanyl or morphine. But over time, it works better for that other kind of problem. So probably I would push it to the limits of tolerability. Short answer, go,
Mhm.
if you're at 24 milligrams, and Todd Stoll would tell us we could even get to 32 milligrams a day with buprenorphine if he doesn't get side effects, to cover him, if you will. But
Mhm.
then try to think of non-opioid ways to do it, and then explain why it's not working quite as quickly as the other ones. And because why I would think that's important is you don't want him to reinforce the idea that buprenorphine will keep him away from heroin, but it isn't going to help his long-term issue, because that'll reinforce the number of times that they go into relapse.
Okay.
But
Okay.
but if you can come in and say, yeah, I get it, you were hurting more, you went to oxycodone, that's a really bad idea for you because of XYZ, but we could manage this. Let's bump this up aggressively, give him a chance, give him some money.
Mhm.
Might be a time where clonazepam, reinstituting clonazepam and talking about the muscle relaxant properties of benzodiazepines might be helpful, just to keep him from getting stressed out and going back to oxycodone.
So
Recognize-
that's interesting that you say that, because this guy, yeah, I mean, we could go into all of his other psychiatric diagnoses, but impulse control and anxiety has been awful for him. And I specifically have 100% avoided even discussing any benzos because of
Sure.
the Suboxone. And he is one, and because of his, history of substance abuse. I don't want to give him another substance to abuse. But it would be very beneficial. He is also on gabapentin, which has been somewhat helpful.
Yeah,
Um,
you're exactly right. Benzos would be terrible in the long run, but
mhm.
5 days of clonazepam might
Okay.
get you. 5 days of clonazepam plus ongoing buprenorphine is a good trade-off for not buprenorphine, oxycodone, and now who knows what else.
Okay. And another problem I've been running into a little bit out here in small town Nebraska is pharmacies. Walgreens is a thorn in my side sometimes.
This takes a village. I cannot tell you how many times Friday afternoon I have somebody saying, you just prescribed a Percocet. What's the matter with you? It's like, well, I'm microdosing, switching over. We had that conversation, but you're right. And the other thing that they'll do is they'll throw naloxone at them when they're putting them into buprenorphine therapy, which gives them, good. We like naloxone, but it gives them the upside down idea, right? So yes, that is for sure a problem. See the big pharmacy where you just kind of have pinch hitting pharmacists, and that's part of our charge. We need to bring pharmacy along with these ideas.
Well, and he's really my only private practice client that I have on the buprenorphine therapy. And I really had a lot of trouble with Walgreens, and finally one of the pharmacists got on and asked me if I had an X waiver.
Yeah.
And I said, and this, mind you, this is long after the X waiver's now been dissolved. And I said, no, I do not. And he said, that's exactly what I needed to know. And I was like,
No, it isn't.
Are
No,
you,
he
are
does
you
not.
gonna like call the DEA and tell them that, like, what are we doing here? But yeah, so anyways, whatever, that's a whole different topic that.
I'm gonna
could go on
throw,
for
I'm gonna
hours.
throw a plug in for our other project. Some of us on this, we're working on a project where we're doing education on this very subject. And we're still teaching the data waiver course and what have you. And as part of the DEA thing, and one of those things is we have a consultation service where we can, you call us and we can help with that. And part of what that means is we end up calling pharmacies, because I can I've gotten very efficient at that discussion, saying, yeah, we're doing this on purpose. This is what microdosing means. This is how you transition. Thanks for calling. I know you're interested in this patient, et cetera, et cetera. When you really want to say, just let me do what I'm doing.
Awesome, okay.
Good
Uh,
case.
Yeah, so, and how can I get, how can people get in touch with you as far as the pharmacy consultation?
We'll throw that out,
Okay,
but that's something that we really want to try to do. And Todd Stoll is super helpful in this area. He's not with us today, but I think, education is our goal, and people's so when we have people who are doing what you're doing the right thing, we want to make sure we make more of that across the state, rather than, make, they wouldn't have called you if you just kept writing 10 of Percocet QID, right?
right. So,
Yeah.
well, and as my private practice grows, and I'm going to be doing care in the community for veterans, which is going to involve a lot of substance use disorders. I imagine. I was just credentialed for care in the community for the VA, so I'm gonna need some
Can I make
people to collaborate with.
I don't think all of you, Amanda Woodward just made a fantastic point where she's had pharmacies call them saying, we won't fill buprenorphine without naloxone.
Oh,
Naloxone is inert, all right? When patients are taking this medication, unless they're putting it on a spoon and injecting it, which they aren't, the naloxone is meaningless until you get 32 milligrams or above. So the naloxone is kind of a REMS idea, is certainly overrated, and it is not what's giving the patients their safety. It's the fact that buprenorphine clings to the receptor and is tightly bound with a long half-life, so other medications will bounce off of the receptor.
okay.
So that's another one, and the opposite is true. If you can get somebody to take buprenorphine to get them off of their hydrocodone and they don't have a use disorder, doesn't matter to me if it's with or without naloxone, if their insurance wants it to be one or the other. The naloxone is inert. It's not doing anything in the vast majority of cases.
Okay.
Stephanie, do you have a comment about that? I know it's putting you on the spot.
No, I agree with you. No, absolutely.
It's an insurance issue, and it's them
Yeah.
putting up unnecessary road barriers and what have you. It's very frustrating.
I typically still encourage everybody to still, provide naloxone and just, give them the 5 minutes of training, because the more people that know about it, the better, right? Because then they can kind of spread that to family and friends.
Exactly.
So yeah, you're right. Unnecessary, but still do it.
Yeah.
Good. Thank you, you guys. That was very
Great.
helpful.
Thanks for bringing that.
Yep, thanks so much. And Amber, I'll follow up with you. Oh, go ahead.
Just as a side,
I'm sorry, go ahead,
just
Stephanie.
Amber, as a side note, just kind of listening to the background of what you provided, given his history and prison history, especially, and kind of behaviors before, of potential. And so, like I said, I obviously know everything about your patient, but just his history in general, we see a lot of ADHD going back all the way from childhood. So I just kind of wanted to throw it out there to see if that was a potential, something you could look into that might be helpful.
I could totally see ADHD and with him. And I have been so, and gun shy is not really that. I've just been very careful going forward with him, just because he has such a complicated history. Now, this guy has given me zero reason to doubt him. He's always been very transparent. I mean, we have an amazing working learning. Just I'm learning more from him sometimes than he is from me. And I've enjoyed working with him. But I always kind of have my guard up, you know, and it's the population I work with. It's, you know, I work with a very difficult population. And so I think you kind of tend to have that guard up and always be on the lookout on, are they lying? Are they manipulating? What are they trying to do? There's always something underlying. And I think I'm better than most maybe about not having that mindset, but yes, ADHD definitely, I think has some bipolar 1 tendencies, but anyway, there's a lot going on there that, so yes, I think that's awesome. Thank you.
Yeah, absolutely.
Well, thanks so much, everyone, for being on our session today. Just a plug, 2 weeks from today, we have Gail Keller and special guest Ken Zuha talking about the success of advanced practice providers in treating patients with OUD. So I hope to see you all for that one. In terms of getting your certificate, an email, there's a link in the chat if you want to grab that certificate now. An email will also come out to you all tomorrow morning. I won't be able to get that out till tomorrow morning, but keep an eye out for that email. And thanks, everyone. Hope to see you in a couple weeks.
Thank you.
Thanks.
Thank you, everyone.